Excellent. Thank you so much. And thank you, Zomedica, for giving me this opportunity to chat this evening with everybody. So tonight we're going to talk a little bit about reviewing lumbosacral disease and conservative management of that, and what that can look like kind of from a multimodal approach. So we're going to start with overview of lumbosacral disease itself and review that. Then briefly mention kind of surgical intervention versus conservative management when we might want to consider surgery, or when we look at versus conservative. What are some of our management principles, the role of pharmaceuticals, our modalities that we may use to help treat lumbosacral disease, and then exercise, more about exercise, environmental modifications, and kind of just a little wrap up. So let's start with just an overview, because before we know like how we're going to treat this, we kind of really need to go back through and review the disease itself and what are we treating and why. So kind of go back to our anatomy. I think this is really important when we're looking at what are the clinical symptoms we're seeing and why, and what are we trying to address. So remember that our lumbar intumescence begins at the fourth lumbar segment, and then the spinal cord narrows and comes to an end near the intervertebral space between the sixth and seventh lumbar vertebrae. There is some breed variation in where the spinal cord ends and becomes the cauda equina, and so medium to large breed dogs, that's typically L6 or L7. Whereas with smaller dogs, it can be one vertebrae caudal to that, usually if they're less than 7 kilograms. And remember that our sacral segments are usually within the fifth vertebral space, and then the functional spinal cord digit ends at that 6-7 junction. Again, another little anatomy review, and I think this is just showing you here where you've got your sacral segments ending in 5 here, and then how it's now turning into the cauda equina. And then I also think it's really important for us to kind of remember that when we talk about where this disease occurs, that it can occur in kind of any of this region here. And we always say lumbosacral, we think of that LS space, but kind of 7S1, 6-7, those areas, but really we can have symptoms anywhere in here, and depending upon how it's affecting it and if it's impinging on the nerve roots, you're going to see different things based upon which nerve roots it's impinging, right? So different nerve roots are going to these different muscles that are being innervated there. So just a little review of that for you. When we look at the pathophysiology of lumbosacral disease, so, you've heard of this as LS disease, degenerative lumbosacral stenosis, lumbosacral instability, cauda equina syndrome. So those are all terms you may have heard. And really, I think of this as a disease because there's multiple potential processes that are going on here, and not every dog's going to have every component of this, which then means it will vary in what we're going to see with their clinical signs. So stenosis that we may see results from that chronic bony and or soft tissue proliferation because of the instability in that area, and the body's trying to stabilize it. You may have a type 2 intervertebral disc protrusion, which is going to reduce the size of your spinal canal in your intervertebral foramen. You may have then varying degrees of compression, inflammation, or entrapment of the cauda equina and or seventh lumbar nerve. So as we talked about, L7 to S1 is the most common site for this, but L5 to S3, anywhere in that area, right, can happen. And since we have foraminal stenosis as a frequent component of this, nerve entrapment can happen with that, which can be potentially a cause then of lameness or even a monoparesis, especially if we're lateralized to just one side. So what kind of dogs are we looking at? What's our history signalment here? So typically, most of our dogs that we see lumbosacral disease in are going to be older, medium to large breed, and they could be working and sporting dogs as well. Now, I've seen some younger dogs with LS symptoms, and I've seen some small dogs with lumbosacral, so it doesn't, they don't always have to fit that model, but that's more typical. The German Shepherd dog is definitely overrepresented. It's more common in males if you look at the literature. And they often can present with, the clinical signs, and the history is going to vary depending on the location and degree of the compression that's occurring, right? So you may just get really vague pelvic limb problems. So it could be trouble rising, reluctance to jump, difficulty with stairs. And this could be, mimic a lot of other things that we see, right? So hip problems, iliopsoas, cruciates even, so just in general, they're just hind end, right? Lameness could be present, may or may not. This could also be vague. This could be intermittent, shifting, unilateral, or bilateral. In many cases, pain may be the only symptom, and this pain could be regional, it could be intermittent, it may be only found on exam. It could be really ambiguous. So especially if we're working with a working or a competition dog, maybe they're just not performing as well. They might be off. They're not wanting to jump, or they're hesitating to jump, or do what we call a hup. So with a hup, we're working dogs, it's standing on their hind legs with their forelimbs resting on a door vehicle, and having to hold that. Maybe they aren't wanting to do that or not able to do that as well as they should. And then some of these guys will develop urinary or fecal incontinence. On our examination, we may or may not have lower motor neuron signs. So sometimes, again, we're just having pain. We're having pain and just symptoms of pain and discomfort, but not actually any other neurologic signs. So this is a plus or minus. So you may have ataxia. And this is typically, again, remember L4-S1. So depending upon where the lesion is, the exam findings, on our neuro exam is going to vary a little bit, which we'll get to in a minute, depending upon that, again, severity of the lesion. So it could have ataxic hind limbs. You could have a flaccid paresis to a paralysis of the hind limbs if it progresses and it's quite severe. You could have atonia to normal tone in the hind limbs, including the external anal sphincter and tail. So that's one of the things we definitely see with these guys, is sometimes their tail's hanging lower, they're not wanting to wag it as well, they're not lifting up because we're having some, dysfunction to the tail itself. Decrease to absent postural reflexes, possibly neurogenic atrophy, hyporeflexia or areflexia to the patella, especially with patellar withdrawal. And then you could have some of these where your neurologic symptom is a nerve root signature. A monoparesis may be present. So everything else is fine, but you get this nerve root signature lameness. If your dysfunction is, if you have enough compression where you have a nerve root dysfunction, so L4, L5, it's the femoral nerve dysfunction. So this is you're gonna see more of that loss of ability to support weight. They're going to be short-strided with a flexed stifle when supporting weight and decreased hip flexion. If we remember, the iliopsoas and the rectus femoris are what flex the hips. And so those hip flexors, quads, and the adductors are innervated by the nerve roots from L4, L5. And then if it's L6, S1, which is probably a lot of what we see, but again, we could have anywhere in here, you're going to have sciatic nerve dysfunction. And so this is going to be loss of tarsal and digit extension, potentially a plantigrade stance, increase in hip flexion when walking because you have decreased tone in hip extensors. And the weight support at the stifle could be normal in some of these. So it does depend. But the glutes and the hamstrings are innervated by those nerve roots from L6 to S1. So on palpation, so on our physical exam, we're going to find pain on vertebral extension versus hip extension. So one of the things I have to say is when you get pain on hip extension, you should put lumbosacral disease on your differential list until you can actually lock out the lumbosacral area to just localize to the hip if you can. Because when you pull the hip into extension, if you're not stabilizing the lower spine, then you could get pain on hip extension from hyperextending the lumbosacral area. So there is, you may get pain on digital pressure over the lumbosacral junction. So, right, dorsal to ventral. There's also this lordosis test, right? So this is a picture of doing this in standing. I prefer to do this in lateral, but basically where you're lifting the pelvis and extending the hips. So you can do this in standing or lateral. You use your hand if you're standing, your knee and lateral is a fulcrum, and then you're extending. So you're trying to localize right to that lumbosacral area and seeing if they're uncomfortable when you do that. You may also get pain on tail jack, right? So kind of hyperextension. So, dorsal flexion, extension of and traction of the tail. And then also rectal palpation. So I have had dogs where all those other things were normal, but then I did a rectal and pushed up from ventral to dorsal. Depending on the size of the dog, it makes it a little more difficult, and they just lit up. And that they had lumbosacral disease. So rectal, don't forget to do your rectal palpation. And then I just put this note in here that we may also have iliopsoas discomfort, because a lot of these dogs I have diagnosed with lumbosacral disease actually came in with iliopsoas as their presenting problem, only to find that the iliopsoas discomfort was secondary to their lumbosacral disease. So to diagnose our lumbosacral disease, we're going to look at radiographs besides our exam, of course, right? So more advanced diagnostics, radiographs, potentially MRI, CT. So for radiographs, we're assessing for vertebral bony changes. We're going to look at wanting to assess the hips, and we're going to want to rule out discospondylitis or other bony lesions, right? Radiographic changes you're usually going to see are ventral spondylosis. You may see some erosive bony changes, facet changes, end plate sclerosis or osteophytes, and changes to that intervertebral foramen shape and size. On MRI or CT, I know probably some people, we do MRI here, so that's what I'm more familiar with for this, but you can also look at CT, and some people do find that quite helpful. But what we're looking for is impingement on that cauda equina or the L7 nerves. So you might see IV intervertebral disc protrusion, foraminal protrusion, dorsal arcuate ligamentous compression. Also nice to check for spinal neoplasia. I currently have a patient who he has both lumbosacral disease and a spinal tumor. So that's always nice to make sure that we don't have that as a component. And one thing to note is that in some of these dogs with more milder symptoms and more nefarious kind of presentations, sometimes this is only really seen in a dynamic when we're moving. So dynamically, when the lumbosacral junction is hyperextending, that's when we see the symptoms. So we're only seeing it at that time. So you may need dynamic positioning, so different positioning in the MRI to actually pick up these, because sometimes they're just static and flat, you won't necessarily see it. And don't forget that older dogs can have changes that may not be symptomatic. So we can see some of these changes and they're not having any symptoms. So remember, we're treating the patient and not the images. Well, this is just an example here of kind of giving you some indication of what you might see with some lumbosacral disease. So here with the red arrow on our radiographs here, you can see clearly there's a bit of bony changes here, and having the spondylosis here, bridging spondylosis. You can also see there's sclerotic end plates. There's not a lot of space in here. We've got, of course, spondylosis other places too, which spondylosis does not necessarily mean there is, it can be non-symptomatic, non-clinical, which is because you have spondylosis doesn't mean there's an issue. But I feel that when it's in the lumbosacral area, it's a little more significant in a lot of cases, because it usually does indicate there's maybe some instability, right? I may not get as excited about it further up, depending on the dog, and what their symptoms are. But the LS, if it's consistent, that's my attention's kind of called to that area. And then here on the MRI, just as an example, you can see here we do have a disc protruding here. We also have some impingement coming from dorsally, so you can see this cord's getting impinged on right here at this space. So what about cats? I hate leaving out cats, like they just never get talked about. So what about them, right? I wanted to throw a little bit in about those guys. So true lumbosacral disease is not as common in cats, but it does occur. And so what we'll see with these guys is spinal hyperesthesia, reduced activity, low tail carriage, maybe ataxia, and difficulty posturing to defecate. So that's one of the things. Sometimes these guys come in oftentimes for constipation or obstipation because they're painful on defecation. Their studies have shown that if they have a lumbosacral transitional vertebrae, they may be an increased risk factor for developing lumbosacral disease. And in spondylosis deformans in cats, there's a study that showed 39.4% can have this. And that does seem to be correlated to behavioral changes in the cat, if it's in the LS region. And of course, as they age, that degree of spondylosis usually worsens. So I do feel personally that I find a lot of cats that do have pain in their lumbosacral area, and especially cats that are having constipation issues. So I find if I treat the lumbosacral pain, the constipation issues do improve. All right, so let's talk about disease management. So when we're looking at managing, of course, we have surgical options, we have conservative options. And I'm here to talk about the conservative options. I'm not a surgeon, but some of the things you should consider, I mean, it's always an option to refer for surgery, or at least for surgical considerations to see if it is an option. So some of this does depend upon the severity of the dog. Also, what's the owner's wanting, what is the owner's outcome? What do they want for this dog? Is this dog a working dog? Is this dog a, competition dog? Can we keep it working longer? Sometimes surgeries may help with that. Sometimes we still are going to have to switch the job of the dog if they are a working dog. If they're failing medical management or we cannot control their pain, those are going to be more of a surgical management. Incontinence may warrant surgery sooner. So ideally, surgery is done before they become incontinent, because even with surgery, they may not improve with incontinence as far as incontinence goes. And depending on the severity with the surgery, oftentimes surgery may not improve them a lot, but hopefully helps them from getting worse. So it just depends. And that's kind of working with your neurologist to see about that as far as surgical management goes. But for conservative, these could be our mild or moderate cases. Surgery is not an option. It's just often not an option for owners. Most often conservative management is tried first anyways. And then also, do we have comorbidities, right? So sort of older dogs, they often have other issues that are going on that would maybe preclude them from having surgery. So when I look at my management principles or considerations for these guys, it is patient dependent, right? And that kind of depends upon a little bit about the lifestyle of the dog, the dogs, what, they enjoy, what the owners want to do, their owner's goals. So there's a lot of things that way that we're going to be looking at. Number one is to address pain. If these guys are uncomfortable, we need to treat the pain. And that's going to be my number one concern. From there, we want to improve and or maintain function, right? So ideally improving function, but at least if nothing else, maintaining function and pain-free function, ideally. Maintain their current lifestyle or improve their lifestyle if we can, manage any compensatory or secondary issues. And then we may have to look at, again, modifying our environment, modifying our lifestyle based upon how they're responding to therapy. So I briefly want to mention pharmaceutical considerations, because really drugs are something, even with all of our great modalities that we have and tools in our toolbox, drugs are part of our tools in our toolbox, and we do often need to reach for these to use in these animals, and maybe we don't need them hopefully as long term if we're using some of our modalities in managing, but we may need them initially or as things progress. So do you use an NSAID or do you use a steroid? And I do feel that's really patient dependent, neurologist dependent, comorbidities present. So I think there's a lot of variation there on what you decide to do. I really like to use this as there's a neuropathic component to this with pain. I really like to put these guys on pregabalin or gabapentin. I'm leaning more now towards pregabalin than gabapentin. I think it's more effective and lasts, better to 12 hours. So I think that's what I tend to go to more. You could add an amantadine if they're on the other medications and you're not getting enough. You can do that. I do low dose ketamine in a lot of my chronic pain patients. It's another thing I add in. And then Tylenol. So I've been reaching and using Tylenol more and more in some of my patients, especially those that can't tolerate NSAIDs. Plus or minus codeine. I think the Tylenol probably actually helps more than the codeine. But that's another option that we can use. Or if they're on steroids and it's not enough, but we can't switch them to NSAIDs, then you could add in Tylenol. And then sometimes, not as often for lumbosacral, but if I have like a really bad iliopsoas component and they're just really tight and tense and painful, I might give them a muscle relaxant as well. So it depends on what else I'm finding compensatory. And then what about those epidural injections, right? So The most common, if this is used, and this is a form of management as well, is going to be epidural steroids for conservative management. Methylprednisolone is the most common ones, and it has been shown that can be potentially helpful for some of these dogs. It will vary. So that is something that can also be done. And then what about the role of regenerative medicine? I mean, you can read and find that people will want to use or try to use PRP, so platelet-rich plasma, or stem cells for these guys. And so I kind of looked into it. I have not injected an LS with these. So I kind of looked myself and they did see in one study, so in people, mesenchymal stem cells have shown that maybe will reduce pain for lumbosacral disease. In a canine study where they injected the lumbosacral discs, they did not really see any significant improvement, but when they injected a case study of one dog, paravertebral injections with mesenchymal stem cells, they did see some improvement. And then there was a small study of 14 dogs that got PRP, epidurals, and they did improve, but similar to other therapies. So I don't know, I think the jury's out a little bit on that, but that might be an option as well. All right, so let's go into our modalities and what we can use. And there's really quite a few different tools that we can use in our toolbox. And for me, I'm going to talk about the top ones here before we get to, of course, exercise, because that one's, of course, another big component, exercise and environmental modification. But we want to kind of go through these modalities. But there are others. I will briefly mention them, but we're going to talk primarily about these top four. So extracorporeal shockwave therapy, the pulse electromagnetic field therapy. Oh, sorry for my slide error there. I thought I got that, but photobiomodulation, which is laser. Sorry about that. And then acupuncture. Okay, so those are going to be the four that we're going to go over here. So when we're talking about shockwave therapy, this is a nonlinear, high pressure, high velocity sound waves, right? So these are about 1,000 times the pressure magnitude of an ultrasound wave. They do differ from therapeutic ultrasonography. It has no thermal effects, minimal tissue absorption, slow frequency. That mechanical energy that's being produced is going to transfer to the tissues in kind of a controlled focal volume. And that energy then creates biological effects at the cellular level, some of which we understand, some of which we still completely understand. But what we're looking at is we are seeing a regulation of cytokines and increase in growth factors. We also can see it's in speeding healing and increasing the quality of the healing, especially in soft tissues and bones. Seeing it can protect chondrocytes, disintegrate calcifications, and even potentially recruit stem cells to the site for healing. We see a reduction in pain. This is thought to be through activation of nociceptors in the area and getting a hyperstimulation analgesia through overstimulation of those nerves via the gate theory. We also can see an increase in nitric oxide, which is going to help modulate inflammation, vasodilation, and increase angiogenesis. So typically, and if you've listened to some other talks here, you've heard of maybe using shockwave for other various musculoskeletal disorders, especially like tendinopathies, arthritis, non-unions, or slow healing, fracture, and now we're putting lumbosacral disease on that list, and even non-healing wounds. So what do we have for evidence of this? And I tried on each of these kind of just find a few studies that we could just briefly just know they're there. You go look at these. Some of them are on PubMed and accessible to you. I will say, though, this qualitative evaluation here, this is actually on the Zomedica's website. So this was an unpublished retrospective study where they looked at cats and dogs where they were treated with shockwave for lumbosacral disease that was diagnosed based on neurologic evaluation, palpation, and radiographic signs. And 89.9% of the animals treated had favorable favorable outcomes on a subjective evaluation by clinician, and 82% satisfaction among owners. And most were seeing improvements within a week of treatment. But median effect was up to 13 months, which I think is really nice. But that's the nice thing about shockwave is we see effect a long time. A lot of times we see for a longer period of time, sometimes in some of our other modalities. And no adverse effects were seen, right? And not all these dogs in the study and cats needed another treatment. I typically do more than one treatment, but they were, I think, just one treatment in this study. With horses, I just found one brief. I mean, there's others, I'm sure, but this was quick search. So they did show that extracorporeal shockwave, help raise the mechanical nociceptor threshold in horses with thoracolumbar pain. So, back pain in general, we see that with horses. So definitely we can use it there. And I know there's more than this out there. This was just a brief one I threw out. But we look on the human side because sometimes we don't always have the studies that we want on the vet med side. So human side, there are a few studies to support it use in the human medicine as well. And there was, in general, improved functional status and decreased pain in leg cramps in people with lumbosacral disease. And then in the study of efficacy and safety of extracorporeal shockwave therapy with chronic low back pain, this was a systematic review, they showed they had better pain relief and improved lumbar dysfunction compared to other interventions with no serious adverse effects. Okay, so of course we always want to make sure that our benefits outweigh our risks, right? So not seeing any significant effects with this, negative effects. So how do I use it? For me, when I'm using it in practice for my lumbosacral disease animals, I'm going to usually do 2 to 3 treatments, 2 to 3 weeks apart. I'm primarily using the Xtrode on anymore, just because then I don't have to shave in most cases. I also have a 5 millimeter, the regular Trode, and I've used that too, both successfully. But luckily, right now with using the Xtrode, most of the time I don't have to sedate. I will say I have had a number of these patients who also may have hip dysplasia and or iliopsoas going on with, and I will also treat those at the same time. And that seems to help in general, because just treat all of it at one time. So for PEMF, or pulse electromagnetic field therapy, these were originally called bone growth stimulators, and they've been around since the 70s. So these are electromagnetic waves that are activating a variety of signaling pathways to help reduce inflammation, increase blood flow, and facilitate healing. There's really more electric than magnetic effects on the tissues, and it really can penetrate all tissue types. So what we're seeing is, if you remember that calcium binding is voltage dependent, and so there's an upregulation of the calcium calmodulin complex formation when we treat with PEMF, and this results in an increased release of nitric oxide. So this increase in nitric oxide, again, is going to increase vasodilation, angiogenesis, and modulate inflammation. There also are other effects seen, so increased heat shock proteins, expression of adenosine receptors, and bone morphogenic proteins. So all those great things. There's also been seen increased growth factors in general. So, in general, we can see these things are in anything we want help with pain and inflammation or healing. PEMF may be indicated. So wounds, arthritis, intervertebral disc disease, musculoskeletal disorders. There is some studies to support using it for anxiety and behavioral disorders as well, and then edema. So multiple different things, but we're talking about lumbosacral here. So what do we know about that? And I will say, unfortunately, there's not that I could find, specific lumbosacral veterinary studies yet. But we do have 2 good studies looking at using it for post-surgical hemilaminectomies, and both those studies that I have listed down here at the bottom, both of them, they improved their pain scores, improved. They didn't need as many pain medications post-surgically compared to not having the treatment. So that can be, I feel, tends to lead to say, well, it should help with lumbosacral disease too, right? When you look though at the human studies, we definitely have some evidence to support using it. So when looked at using it for cervical and lumbosacral related pain, they found that PEMF therapy seemed to reduce pain intensity and improve functionality in patients with those diseases. Another study looked at it was a systematic review of using PEMF for non-specific low back pain. And they basically found with that it did seem that PEMF was safe and beneficial treatment option for non-specific low back pain, especially when it was used along with other conventional physical therapy modalities. So definitely an option to be used in this case. So how do I use it? So I like to use it post-operatively in hospital, during outpatient treatments, if I have, especially during acupuncture. So most every one of my acupuncture patients is going to be getting PEMF at the same time. They're usually on a PEMF bed. And I am doing acupuncture for lumbosacral disease which you'll see here, especially for my cats. They love it, so they do really well. And then the nice thing is this is a home therapy treatment, right? So we can send home the loops, we can, or they can buy like a lounge, a bed, and they can be using it then, post-op early or conservative management at home. How often this is going to be used is going to depend on the patient and the severity of discomfort, but it can be used up to every 2 hours if need be. So what about laser? So I do use laser quite a bit in practice as well as another modality. And so with laser or photobiomodulation, we're seeing our light energy or photons are stimulating cytochrome C oxidase, which is the last subunit in our electron transport chain of our mitochondria. It's a photoacceptor, and so it's sucking up our photons. And what we're seeing with that then is you're seeing improved cellular respiration and metabolism by improving and normalizing cell function. So this is in damaged cells. And you also see an improvement and increase in ATP production, which is beneficial for many things. We'll also see as a byproduct the increase again in circulating nitric oxide. That's that nitric oxide again, and that's going to help decrease inflammation again, vasodilation and angiogenesis. Oftentimes we're using this, for a variety of reasons in practice: post-operative incisions, wounds, arthritis, soft tissue injuries, intervertebral disease, edema. So all those are potentials, and there's more, but those are some of the more common things you're going to see. So what do we know about this as far as literature goes? So kind of mixed reviews when it comes to specifically lumbosacral disease with laser. I will say that in the human side, and I've listed several here, there's mixed reviews on the human side. So there's been some studies that have shown that it did benefit for low back pain. And then others that were not as great of improvements as they would have liked to have seen. No harm necessarily done, but just maybe not significant improvements. In the dog, we do have evidence to support using this for post-op IBDD, but again, it's kind of mixed as far as our effectiveness. And a lot of, for those of you who are familiar with laser and utilize it, some of the issues with this is just there's a lot of variation in products and a lot of variation in dosages, and there's just a lot of parameters. And so some of that is probably part of the issue why we're seeing so much variability, but I do think it plays a role and it's something that we can use. So how do I use this then in practice for my lumbosacral ones is I like to use it in between shockwave therapy treatments, potentially, if they're coming in for rehab, so if they're coming in for exercises and other things in between, and I'm not always doing shockwave every visit because they don't need that, I might use that. Or if they're a patient that has more significant neurologic impingement or things where I might be more concerned about using a shockwave, then I'm going to maybe use this along with PEMF. I use laser and PEMF together, not at the same time per se, because you're doing some of the same things, right? And so you might I don't know, it's just maybe wasting one of your treatments that way, but I may PEMF one region, laser another. That can happen. So, sometimes I'm using all these things kind of together. Really, a lot of times I'm using this also for other comorbidities, post-op on the incision. Occasionally, I have a noise phobic patient. They're just not going to tolerate shockwave, and I can't sedate them for some reason. This is pretty rare, but that might be a case. Again, more severely neurologic affected patients, along with PEMF at home, skin wounds. Cats absolutely can use shockwave in cats. I just find that, sometimes owners are a little more resistant because typically if I'm going to have to sedate anybody, it's probably going to be the cat. So, they're not going to be as keen on that noise. So it just, it's going to depend a little bit case by case. And then lastly, for the big one here is acupuncture. So acupuncture, I really like to use in these cases too. And again, I can use this along with my other modalities to help with, these are, a lot of these guys are going to be chronically managed cases. And so to enhance the outcomes and lengthen, how long we go before we, are going to worsen our symptoms, right? Maintain their quality of life for longer and maintain function for longer. So acupuncture has been shown that this is going to help decrease pain at, every level of the pain pathway. And no time to go into that, reviewing all that, but just keep that in mind. Locally, segmentally at the spinal cord, which is really the main level of pain relief, but it's going to affect all the others, and centrally as well. So a lot of this is working again through the gate theory of pain there. And so that's at that spinal cord level, helping to block the ascending transmission of the pain signal to the brain. We also will see an increased release of endogenous opioids and serotonin. And that's going to be beneficial for globally improving the patient. May also modulate motor reflexes of the spinal cord. So if we do have some of that neurologic dysfunction, that may be beneficial that way. Increasing blood flow and circulating stem cells. Ideally, electroacupuncture is going to be the best for these. You're going to have better, I think, responses and longer effects if you can use electroacupuncture. And again, great for cats. So this is my go-to for cats. This along with PEMF, plus or minus laser. And then, maybe I'm going to throw Shockwave in there, depends on the cat and the owner, but I think cats do respond nicely to acupuncture and PEMF combination. So what do we have for acupuncture? And actually, there's quite a few studies to show that acupuncture can be very beneficial for lumbar problems, primarily on the human side. So we have acupuncture studies kind of for general back stuff for dogs. So there's been a retrospective study of looking at using it for, thoracolumbar intervertebral disc herniation, neurologic conditions and musculoskeletal diseases in general, and quality of life. So these show that did improve these patients in veterinary studies. When we look at the human studies, though, we do see definitely favorable outcomes. So acupuncture in one study showed a more favorable outcome than lumbar traction, NSAIDs, steroids, and several herbal formulas. There was another study that was a comparative study that was looking at acupuncture versus physical therapy for improving functional score, and they found that it was actually better than PT for improving functional score, but more effective than the medication for satisfaction score, so kind of a mix there. And then electroacupuncture has been shown to help improve symptoms of lumbosacral disease, especially when used. Needles are placed near the nerve roots where they're going to be, and it's also shown to increase sciatic nerve blood flow with lumbar muscle acupuncture, and then also with pudendal and sciatic nerve stimulation. So I think it's pretty neat to look at that, and I know that we're doing that with our acupuncture. So how I utilize this is going to be again, conservative management post-op patients, part of my multimodal pain therapy. I usually start this more frequently at first, and then I start to space out the treatments over time. Really great for patients with other comorbidities because we can kind of treat them globally. And then our incontinent patients, I think that this sometimes can help those guys. I have seen these guys get better incontinence-wise in some cases with acupuncture. So there's other things. I'm not saying that these aren't other things that we can definitely use. These are appropriate as well. Just time precludes me from talking about them as much. But TENS, so transcutaneous electrical nerve stimulation, especially for pain. I've used that on a few of my LS dogs. And also you could use opposite the NMES, so the neuromuscular electrical stimulation, if we're working on muscle retraining for our neurologic patients. Thermal therapy, so heat, ice, depending upon surgery, not chronic, acute, all those things, but definitely thermal therapy can play a role. Kinesiology tape, so I've been using that more and more, and that can be utilized for a variety of reasons. And then various manual therapies, right? So massage, mild traction, I usually do tail traction, not lifting up on the tail, following the curvature of the spine, and light tail traction. That does actually make some of these guys feel better, I feel. Instrument-assisted soft tissue mobilization. And then these guys can often have compensatory restrictions and problems, right? So mobilization or manipulation of other areas where we're having restrictions can maybe make them overall feel better and move better. So what about our exercise and environment? Because this is also a very important component when we're looking at managing these patients. So exercise, this is always a cornerstone of treating patients for us, right, for physical rehabilitation. And This is a variety of both. We're looking at using exercise to help improve the patient. Sometimes we're actually using it to help prevent them from worsening or getting them better, retraining neurologically. And then we're also having to look at exercise modification in a lot of cases too, right? So how many modifications are going to need to be made to exercise really is going to depend upon the patient and the degree to which they're affected. So think of things that are going to hyperextend the lumbosacral area. Those are things that may irritate, right? So jumping, maybe stairs, things like that are going to be potentially a problem and exacerbate symptoms. So if you've got a dog that is an active hunting, agility dog, things like that, maybe they're more minimally affected. You treat them, they feel better. Are they going to be able to go back and do their activity? Maybe. It really is going to depend on the patient. So you kind of have to take those, a lot of client communication and take those step by step. What exercises we're doing and what kind really is going to vary, because it can vary from having to neurologically retrain and do a neurologic retraining kind of rehab to preventative rehab. So when you mean preventative, core stabilization. So we're going to talk about the studies they show here for humans on exercise. And they're always talking about lumbar segmental stabilization exercises. So we can, improve our core and stabilize those core. That's going to help stabilize the lumbosacral area, right? So core. Can't emphasize that enough. And that's going to depend upon, there's a lot of different exercises out there to work the core. But this one here, as I just put a demonstration of, this is a cross-legged balance, or Snoopy, some people call them. This is one of the exercises we can use to work on core. So a lot of balance exercises are things that we're going to be looking at. And just remember, be careful with exercises that might hyperextend that lumbosacral region. Can they return to sport or work? It's going to depend. So exercise-wise, we fortunately don't really, that I could find, have anything much to talk about as far as that med goes. But on the human side, every really study, a single study I found that talks about lumbar stabilization exercises all seem to help improve function and reduce pain, even walking. So like this one here was effective lumbar stabilization and walking exercises on chronic low back pain. And so they were really encouraging that. So all of these things were things, you can look at all of them, but all of them did seem to improve functional and pain scores. I will say the one of the 12-week stabilization exercise and sling exercises, which sling exercises, I had to look that up because that's a closed chain load bearing exercise using suspension. They did find that it didn't necessarily affect how much lordosis a person had or their lumbosacral angle, but it still did improve muscle strength and decrease pain. Okay, so exercise, both modification and instituting exercise, we don't want these guys not moving. They need to be doing things, is going to be beneficial. And then environment, right? So environmental modification is going to potentially be needed. And this again is going to depend upon your scenario. It depends upon the amount of disability the patient has, right? So they may not need all of these things, but just some things to think about. We may need now, they can't jump into the car. We need to have steps or ramps, right? And shorter steps, that type of thing, or ramps. Nice, comfortable padded bedding. Looking at that. Flooring. So flooring is huge for me. I ask all my clients, one of the questions I ask on their history form is, what kind of flooring do you have in your house, right? So do you have carpeting? Do you have hardwoods? Do you have linoleum? Because if these guys are slipping and sliding and having problems, and that's not going to help them, especially if they've had an weakness going on or any other issues going on, or they have some instability back there. So making sure we've got good flooring and traction. Let's also think about nail health when we think about this too, is making sure that their feet are groomed properly to help with traction. Elevating the water and food bowl, that is more for I think for me, it's almost for these guys with hind end issues. I like to kind of get them up to a more neutral stance, and that kind of makes them shift their weight to the back end a little bit and makes them work a little bit more. So a lot of animals that we see with hind end problems are shifting a lot more weight forward to compensate. They're also then getting caudal shoulder area trigger points and soreness. have that, or exacerbating borderline orthopedic diseases. If we can kind of get them back to where there's more, neutral, that's actually kind of an exercise for them too, right? So I think it's always nice to have, not too high, but, kind of neutral, to where they're kind of keeping a neutral spine. And then for cats, so cats, we need to remember that one of the biggest reasons why cats will start to have inappropriate urination, defecation, or accidents as they age. Yes, absolutely, they'll probably have some kidney dysfunction, but a lot of it is arthritis or lumbosacral disease or pain in general that's precluding them from getting into the litter box and out of the litter box, or posturing. So low entry, large litter boxes, they can have plenty of room, but this low entry is really important, and it's someplace they can easily get to too, right? Like if it's their bed's in one room in the house and the litter box is down several flights of stairs in another part, that's not going to be very helpful, right? So making sure we have easy access, and same for food and water, right? These guys aren't moving as well as we need to make sure that they can get to where they need to be. So assistive devices, again, this will depend upon the severity of our dogs, but if we do have, cats not as much maybe, they're not as big of fans of assistive devices, but for our dogs especially, as their disease progresses, or if they have significant neurologic dysfunction, we may need to be looking at some of these things, right? So we may need to be looking at traction for their feet, so that could be grippy socks, could be toe grips, could be boots. We also could need, maybe they can't, they need a toe up device here. They're knuckling a lot and making sores, and maybe they just need a little help, like just a little help to help them up. So there are different toe up devices that might be an option for them. Maybe we're having trouble getting in and out of the car, or just getting up a little bit, and they just need a little more help. And depending upon your client's lifestyle and your client's physical capabilities, right? A lot of times we have to stop and think about, what can our client actually do? And if our client is maybe themselves has had back problems, or they're maybe elderly, or have some kind of medical condition, and then they have a large dog that now all of a sudden can't get around very well, that's going to be a problem, right? So we got to figure out things that we can do to help the client help their patient. And so one of those is going to be potentially putting them into something like a help them up harness, you can see here, or another form of harness that's going to help them get them in and out of the car, up and down, those type of things. If we do get to the incontinent stage and owners are wanting to, to help manage that, then we need to talk about skin care. We need to talk about, maybe we're going to need to use diapers, bedding, things like that. That's kind of a whole nother can of worms, but those are things we need to talk about and have conversations with, because these guys can get urine scald, they can get, it can get rashes. And so owners really need to be aware of how to take care of that properly, to give them a good quality of life. And then maybe they need a wheelchair, right? So maybe we're going to get to that point where the owner wants to use a wheelchair to help them get around, or they're going to become wheelchair dependent, or maybe they're not wheelchair dependent yet, but they just need a little bit of something to be able to go for that walk for a little bit longer, right? Just a little bit of support, and they can still move, but boy, they can move a lot better when they have that wheelchair to support them. So I think that there's a lot of uses potentially for this, and maybe something we need to use in our lumbosacral dogs, depending again on our owner. So key points, remember that this is a progressive degenerative condition, that again, but it's going to really highly vary in how it presents, what we're going to see, what the severity is, what its progression is going to be. All those things are going to vary, right? And pain may be the primary problem we see. But that can affect a lot of things. So just keep in mind that oftentimes for lumbosacral disease is the first thing we see, and maybe the only thing we see. And if we can catch that early and start changing things, maybe we won't hopefully develop into the more neurologic component, but we can have, again, it can vary. Commonly it's affecting medium to large breed older dogs, especially that German Shepherd has to be high on our list of things that it can have. We are seeing more and more working dogs, competition dogs who we're seeing lumbosacral disease in now. Is that because there's a genetic component and we're seeing, because we have a lot of the same breeds in those competitions, or is it because of what they're doing? We don't know yet, right? So, but it is something to put on our list if we're starting to see some issues, that maybe there's a component to that as well. Pain may be the primary problem. Conservative management is often the most common thing we're going to do, right? And again, we're going to need a multimodal. We always say that all the time, but we do. We need a multimodal management. There is no magic, one thing treatment for these guys. There's many things to consider. But oftentimes, realistically, our owners, not that surgery is not an option. You should always recommend a consult for them to have that if they want to do that. But conservative management is absolutely the most common thing. And we see lumbosacral disease so much out there. So, or at least some component of it, right? And then we got to tailor our treatment to the patient, and the client to some extent, right? Lifestyle and things too, but definitely our patients, it's going to make a difference. Depends upon what that animal, how they're going to respond to therapies, what kind of therapies, or what's their lifestyle, what are our goals, all those things, everything needs to be tailored.